Hello and welcome to the Health and Adult Social Care Scrutiny panel. My name's Councillor Jackie Ramsey and I'm chairing the panel today, and I'd like to just ask the members of the panel if they wouldn't mind introducing themselves. Can we start with you please, Leslie?
Hi, I'm Leslie Warner, Councillor for Combe Valley.
Hello, I'm Alison Munro, Councillor for Almondbury Ward.
Hello, I'm Kim Taylor, Voluntary Co-op-T.
I'm Helen Clay, Voluntary Co-op-T also.
And Vivian, can I come to you at...
Thank you, Jackie. Councillor Vivian Lees Hamilton, Murfield Ward and panel member.
And I'm Councillor Liz Mage, I'm Chair of Scrutiny and I'm here to observe, although I generally don't manage it, but I'm here to observe, thank you.
And Yolanda, do you want to just introduce yourself and then we're done?
Yeah, I'm Yolanda Myers, Principal Governance Officer, looking after the meeting with Councillor Ramsey.
Brilliant. Okay, we'll ask people that are presenting to introduce themselves at that stage, if that's all right. Can we just have a look at the minutes of the previous meeting? Are we content that they are an accurate record?
Yeah. Yes.
Yes.
Yeah. Okay. All right. Can I just ask that if we've got any councillors that do have any interests with today's items, that they actually declare them?
Yeah, I have to declare an interest as a member of the Calderdale and Huddersfield Non-NHS Trust Council of Governors.
Thank you very much, Leslie. I'll tell you what I forgot. Apologies. We've got a couple of apologies for today, haven't we? We've got, is it Joe Lawson, Bill Armour, as our apologies? Yeah. Okay. So the meeting's in public. Will be put on YouTube, so you'll be able to check yourselves later, hopefully. No, not. There were deputations or petitions? Okay. No questions? Okay, that's lovely. So we're into our first item, which our first meaty item, which is adult social care. And I think, Richard, you're starting the presentation, are you? Would you mind making sure that people know who the members are that you've brought along with you? Thank you.
I wonder whether we might start just by doing some introductions and then we'll move on. So I'm Richard Parry, Strategic Director for Adults and Health here at Kirklees Council.
Thank you, Richard. Hi, committee. I'm Saf Boot. I'm Head of Service for Adult Social Care in the Council, but also Head of Service for Locala.
I'm Karen Pogson. I'm the Registered Manager of Active Social Care Limited. I'm also the Chair of the Kirklees Registered Managers Network and member of Kirka.
Hi, Michelle Cross, Service Director, Adult Social Care and Health.
Hi, James Cregan. I'm the CEO of Kirklees Care Association. I'm also a provider of nursing and residential care in Kirklees.
Hi, my name is Phil Gould. I'm a Service Development Manager of the Integrated Commissioning Team at Kirklees Council.
And I'm Emma Hanley, Senior Contracting and Procurement Manager at Kirklees Council.
Great, thank you very much. Panel members will have had both the report and the slide pack in advance. So we've already done a set of introductions. I think we're going to have a fairly broad conversation today about the state of the social care market in Kirklees, particularly domiciliary care, so that's care into people's own homes, residential care, some of the wider social care workforce, so thinking about social workers and similar, and then a bit about the role of intermediate care specifically within that mix. That would be good. Yeah, thank you. So just for absolute clarity, the content of the slides that you'll see is the same as the content of the slides that you've had previously circulated. There's been some slide changes, which is we've upped the font size on the ones that hopefully will go on the screen just to make sure they were visible. And I think there might be one that's been split over 2 slides just to make it easier to see on the screen. But particularly as I thought we might have been in the council chamber, but the content is the same content that you've previously seen. When we've been through the presentation, in terms of questions, Michelle will, in a sense, receive questions and kind of indicate the person is probably best placed to speak to them.
I think, to be fair, is it coming?
Yeah. Super. So we'll just move on a couple of slides. And on to, that's it. So I'm going to start with a bit of kind of national context off the back, as you've seen it in the paper report, a couple of national pieces of work. One was CQC State of Care report from last autumn. The other was a report undertaken by ADAS. ADAS take a number of surveys from councils across the year to understand what's happening in social care delivery. And nationally, what that was saying is we're seeing quite a significant increase in the number of councils that were seeing the handback of care packages or the closure of care homes in their area. So the majority of councils experiencing that, and in Kirklees we've seen a number of care home closures in the last year, more so than we've seen. There are periodically care home closures, but we have seen more in the last year than we've probably seen in the preceding 5 years. And nationally, there's been an increase in the amount of home care delivered, but equally in many councils, a gap between the amount of home care that was needed in that council area and the amount that was actually available to be delivered. So many councils running effectively a home care waiting list from a very small number of hours to many thousands of hours in some councils. And as we'll go on to see later, the Kirklees picture is somewhat different from that in terms of particularly home care. And whilst some of this data kind of came through last winter when we were at the point, obviously, of COVID still having a significant impact on workforce availability, we do know that some of those shortfalls in the availability of care are year-round shortfalls in some council areas. But locally, we've been in a position where, as I say, we've had some care home closures, but actually we're in a position where we support comparatively few older people to live in residential care and nursing care compared with some other councils. It plays a very important part of the mix of social care, particularly for individuals with more complex needs and where they're getting towards the end of their life. But we've been able to more than double the amount of domiciliary care that's been available in Kirklees. So we don't run a domiciliary care waiting list. It is literally a handful of hours most weeks. And that's typically a couple of perhaps more complex packages in a more rural area. And what we do know is we're a bit of an outlier in a different way, really, around younger people with more complex needs, where we have a comparatively higher number of younger people living in residential care. And that's to an extent to do with our available housing offer. So there's quite a lot of investment going into new housing stock that will make supporting people in their own homes easier. So quite a lot of bungalow development coming on, and a number of other sites where we're looking at being able to develop better quality, more accessible housing for people. So just moving on a slide, there's at least one elected member colleague in this room who will remember a care home in North Kirklees called Oxford Grange, which closed, and we did a safeguarding adults review off the back of that, and we shared the findings of that with a previous iteration of the scrutiny panel. And one of the findings from that was that actually there was lots of support available to care homes, but that it wasn't necessarily joined up particularly well between the then 2 CCGs and the local authority, and indeed CQC. And off the back of that, we created a joint board between the local authority and the 2 CCGs, subsequently the local authority and the ICB, to better coordinate the offer of support to the care sector. And that over time has evolved. It's supported the sector more generally through the pandemic in terms of things like IPC arrangements and in terms of supporting care homes to deliver services safely. It's now broadened out and is going to work across the whole of the care sector, supporting domiciliary care as well, and has both James and Karen as kind of members of that board. So it's moved from being just a commissioner board to very much in a kind of co-produced space, with a work plan that you can see below around market sustainability, around managing quality, which was one of the issues that the board was first set up to do, around workforce, because we recognise actually the workforce is key to quality and sustainability. Working through what a training, development and support offer can look like, and some early conversations about how we might have much more of a system-wide offer, and thinking about the role of the NHS in providing training, development and support opportunities to independent sector providers, and thus ending up with a much more kind of coherent programme of work. And so work around digital, and there's been quite a lot of digital investment around kind of record systems and so on to support the care home sector. But I talked about workforce, and at this point I'd like to hand over to Michelle to talk a bit more about the adult social care workforce in Kirklees, because ultimately good social care is entirely reliant on the workforce that we have available.
Thanks, Richard. So I'm going to go, next slide, please. Just going to take you through some of the key headlines that affect Kirklees, and go through some of the numbers, which I'm sure the panel will find interesting. So there are approximately 10,500 posts filled across Kirklees, and that's within the independent sector and across the local authority, with an additional 1,200 personal assistant posts employed by direct payment recipients in Kirklees. Of the 10,500 posts, 75% of these are in direct care roles, and it'll be of no surprise that 82% of those are female. And you'll see from the figures presented a breakdown of people's age profile on there. 51% are part-time workers, and we have 19% turnover, which you'll see again from the slide is lower than the regional and national average. So that's a good news story for Kirklees, and 67% are recruited from within the sector. I think there is further strategic ambition and further work that we do with our network colleagues and the Care Association in wanting to increase the workforce capacity. That inevitably will reduce pressure on hospital discharges. Also, just to say that we want to increase personal assistance across the sector, providing more personalised choice and care for Kirklees residents. We also want to support local people into jobs in Kirklees, and that will inevitably have a positive impact on the economic activity across Kirklees. We're still working on assisting providers around retention issues. We know nationally that is an issue in terms of social care, but providing good matches and applicants that have the right values and attitudes is something we are aspiring to achieve. And increasing the number of diversity new entrants into the care sector is something that's certainly something we're striving to do as well. And I think it's fair to say retaining and developing staff through a really good career progression, and we have seen that. We've seen people move into more senior roles through really good training and development within the roles that they're in within the sector. Next slide, please. So further work that we do within Kirklees, we have our Intercare service that provides bespoke recruitment and support, and that's to increase workforce capacity across Kirklees care sector, doing really good tailored one-to-one job matching, provider advertising, employability training. There's a whole raft of things that Intercare do across the associations and with independent sector providers. We've seen provider advertising, and we've done some really good recruitment events over the last 12 months. We've done those in partnership with our care association. We've done them internally, externally in the council, and we have seen a significant amount of footfall through those recruitment events. We've done them in town halls. I think we did one at Brian Jackson Centre, and we saw a significant amount of people really interested in care. Probably for the first time since the pandemic, we've seen people wanting to understand what care means, wanting to come and understand the roles that we've got throughout the sector, and that's not just within the council, that was right the way across the independent sector. I think Intercare has evolved since 2017. They did win a Guardian Public Sector Award in 2019, which was great for them, but there's further work to do, and I think you'll see from the figures presented up there, we have supported a significant amount of people into the care sector through that model. So it is something that other authorities do look and want to come and understand how we've managed to do that, what our Intercare offer is in Kirklees. And I think, you know, considering opportunities such as what the council can offer to its council employees has been really attractive to the independent sector. Things like discount schemes for VivUp, which is our new council scheme for discounts across high street and supermarkets, and CAL discounts has been an attractive, very, very attractive to new people coming into the sector. We are considering looking at development of a joint staffing bank to provide more cost-effective and quality short-term staffing solutions across the sector. We all know that reliance on agency is very, very expensive. So if we can create something that's joint across the council and within the sector, then there's economies of scale through doing that work together. We're also, I think Richard alluded to this, we're currently developing and refining our learning development offer, that the offer goes out right the way across the sector, and including direct training, a train the trainer, and resource sharing across the wider sector, and that does include training our personal assistants. So it's not just internal and external, it's those who are providing direct care through direct payments as well. And I think I said something similar, but we have supported a number of leadership and management training to develop existing and aspiring managers, and the take-up of that has been well received. Next slide, please. So again, just to say our Intercare offer, what does that do? We want to further work with Kirklees Care Association and integrated partners on increasing the number of entrants into social care, continue to work on our recruitment and retention issues that are difficult across the sector, and further work on our development and training offer and development of integrated workforce strategies. Next slide, please. So on to domiciliary care. In January 2023, on average, there was 1,330 people per week in Kirklees receiving funded domiciliary care through adult social care. There are 79 home care providers operating in Kirklees, and Karen is here as representative of those. You'll see from the figures again, there has been a growth by 59%, and that's 492 additional home care recipients, which is significant, and that has increased by additional 8,900 hours in Kirklees since April 2019. And I think Richard equally said that we have seen service users receiving more intense support packages over the last 12-18 months, and that has risen by 72%. But again, unlike many places in the country, Kirklees has a minimal waiting list for care and support within domiciliary care, and this has been a result of investment into pay rates for care staff. And I think working with Intercare and support with recruitment and retention into the sector, but also work with our occupational therapists and reablement services to maximise independence and reduce people's reliance on services, has had a massive impact on this workforce as well. Thank you. Next slide, please. Sorry, it's a little bit small that, so hopefully you can see that in your pack, but just wanted to illustrate some of the CQC ratings that we have across Kirklees with a bit of an illustration of quality that we've currently got. You'll see that there are a number of home support services that are in outstanding and good. We do have a very robust process in place in the council to support providers where they are deemed requiring improvement, and if we want to get into discussion later, we can talk you through what that looks like and how we do that and how we manage quality and how we support providers in Kirklees. Next slide, please. So then on to care homes, just to give you some figures, we've got 125 care homes in Kirklees, and that equates to 3,489 CQC registered beds. That has reduced by 5 homes since 2020, but I think in order we have seen reduction in the number of people living in care homes as the pandemic hit that sector hard. We have seen an increase over the last 12 months, and that's now only slightly below pre-pandemic levels, which again is a good news story for the care home sector. We do have sufficient capacity across the care home providers currently in Kirklees, and I just want to point out that during the pandemic, CQC they ceased to do on-site inspections. However, they did continue to monitor services long arm by provider information returns, notifications if there were issue in the home, and if there were any significant safeguarding alerts, that would have made sure that CQC did come out and do an inspection. They are now back out doing inspections. We've seen several across Kirklees. They are concentrated on areas where services are deemed requiring improvement, and through some recent inspections, we've had some unannounced, we've had some virtual inspections, and we've had some planned inspections. A majority of those that previously required improvement are now getting good ratings, which is a really good story for Kirklees again. Next slide, please. So again, this just shows you care home ratings in Kirklees. Again, you'll see quite a majority that are up in the green, which is outstanding and good. And again, we have some that require improvement, but I think that, like I said, I've explained what we're doing in terms of supporting those providers. If there is a question around which might come up about some of the non-published ratings, that is generally newly registered companies, usually inspected within the first year, or changing of ownership, company structure have been inspected, but the report is not yet published. And you'll see that year on year, because obviously companies come into the market, companies go out of the market, and sometimes if it's a change of ownership, those aren't published either. So these catch up every year. So I know the numbers look quite stark when you look at them, but that's just an explanation of why those figures are there and those percentages. Okay, thank you. I think that's it for my bit. I think I'm going to hand over to Saf.
Thank you, Michelle. So maximising independence and improving the pathway from hospital to home are at the heart of the vision for adult social care, and that was the vision for adult social care was presented in the wider report for the committee. Community intermediate care beds and the short-term support that's provided in people's homes are part of the joint efforts with our partners to deliver safe and effective rehabilitation and recovery services to people who otherwise face unnecessarily prolonged stays in a hospital setting or experience an avoidable admission to hospital. So in Kirklees, we deliver these services through the KILT partnership, as we call it, or the Kirklees Independent Living Team partnership, which brings together a range of services under one pathway, under one partnership model, providing a single point of access for intermediate care. The ethos we share as a system is that home is best, and that the KILT approach facilitates the system-wide efforts around home first, as we call it. The current service offer for bed-based intermediate care is for 50 beds provided through 2 sites. That's Ingsgrove House in Mirfield and Moorlands Grange in Netherton. Now, these are council-run homes with joint teams providing the care input, the nursing and therapy input, as well as the dedicated medical cover that's required within those settings. Now, the committee may recall that I presented a set of proposals back in December 2020 following a review of the intermediate care provision in Kirklees during the summer of 2020, and that was to seek the feedback from the committee on a set of proposals to improve the bed-based offer for intermediate care in line with some of the emerging service models such as discharge to assess and urgent community response. And on the back of that, the bed offer in Kirklees was reduced from 60 beds across Kirklees down to 50 beds, with more of a focus on the home first type solutions that we provide in people's homes, such as reablement and therapy input. Now, the Council and partners are currently undertaking a further review of the intermediate care bed base, and that's to ensure that the model has got a good fit in the current operating context and the challenges that we're faced with, particularly with some of the challenges across the secondary care or hospital sector. This includes ways in which we're exploring how the joint teams can act as one team, how it's a better experience for people who navigate through the bed-based setting, but also the opportunity for people or patients to have a good transition home through the offer of reablement. Now, we know that we don't get that right and it's not perfect and there's still room for improvement, but the fact that we're operating as one unified team across Locala, Kirklees Council and other partners, I think that's going a long way in supporting the experience of people who use those services. Next slide, please. So we've talked about the workforce already quite a bit, and Michelle's covered it, so I won't go into a huge amount of detail, but just to echo that a valued, healthy and motivated workforce with the right skills, the confidence and the capacity that's required is absolutely crucial to achieving the plans that we've shared with you today, but also the aspirations that we've set out in the Council Vision for Adult Social Care. The national workforce challenges are well documented, and we've provided additional local insights in the detailed report. But key points just to pull out at this stage are mainly around the social workforce, and they're presented on the screen there. Now, within adult services, we have a dedicated work stream that's focusing on workforce recruitment retention. It's got input from wider council partners, particularly colleagues working in sort of the economic regen part of the world, as well as HR, etc. And it also accounts for some of the impacts that we've seen, that you've seen on the slides earlier, through Intercare and some of the efforts that have been input as part of the wider care sector. And that workforce retention or recruitment retention group provides the overarching governance for some of the efforts within the service. And we've seen that already it's yielding some results. So one of the bullet points there references the number of social workers that have started in the council against those that have left. But we still recognise that, workforce is a complex issue. It's well documented nationally. It's an issue which probably requires a partnership response and a response which is a little bit longer term. So that's something we'll continue to endeavour our efforts against. Thank you, and we'd be happy to take questions and inform a discussion.
Thank you very much. Thank you for your presentation. We're going to take questions in order from the panel, if that's all right. We'll try and tie things up if there are a few questions on the same thing. But Leslie, if that's all right, would you want to go first? Relatively succinct.
Yeah, a couple of points, well, 2 or 3 points. I mean, firstly, what you're presenting sounds like, you're doing a lot of work to try and address what we know are a national, it's almost verging on a disgrace. Once again, social care has been pushed into the back burner. Once again, generally, people can earn more money in a supermarket and looking after dogs than they can looking after old people. And until we as a culture and a society value probably the most important part of a person's life, apart from when they're first born. So, it's quite shocking to read what we know anyway of the figures and the turnover. And, I wonder how much work, just as a thought, in terms of linking with schools, the whole variety of citizenship things and whether there's low-key things where some young kids can be really frightened of being in a, care homes full of all these mad people in wheelchairs or whatever. And actually when they go in, and there's some evidence of some quite good bonding. The other issue I wanted to raise was, actually I was at a meeting last night that Colne Valley, because I live in Slowett, Colne Valley Care Cooperative was feedings in some of the, brilliant view and supported by the council. But X years on, they are still struggling to break even for all the reasons that, pay, staffing retention, they just recruit fantastic new people and then they leave because they're tempted away by more money somewhere else. So just wondering how you address this. There was another thing that was also raised, and I'm going to say this, was that when you are applying, or when the care home are applying for grants, a funded application that they have to fill in to get the money where you're paying, where Kirklees is paying for that place. They said you'd think we were asking for a new highway to be built. Is there not a way, given how busy everybody is in the care sector, of making the application for a funded place simpler? That's just a practical question.
Michelle, I counted 4 in there, so good luck.
Quite multifaceted, is that? No, it's okay. No, it's fine. I mean, to break it down, workforce issues, absolutely national issue. What we're doing locally, some of sort of the care. Did you say about care home placements? Sorry.
The funding to get a funded place through the social care cooperative, the form that needs to be filled in sounds like it might be quite daunting.
Okay. Do you want to take the first question? And then I think there's a couple that I might ask Emma to respond to in terms of how people apply to be on our framework, which is probably what the cooperative are talking about, because I spoke to Sue Richards reached out to me last week asking for support and guidance. So we have sent Sue and we are in conversations with Sue. So we might be able to just alleviate some of that kind of issue there. We'll try our best. Is that okay, Richard?
Yeah. So, and I think we'll bring in James, Chief Executive of the Care Association. There's something about this is, whilst we have relatively good performance in Kirklees, this is something about that, it does require a national solution. Yeah. And you're absolutely right to say, we want to be bringing young people into the sector, but they should be aspiring to come into the sector. And when they are working in this sector, they should be doing so and receiving just a pay rate that reflects the value of the work that they do. And I think no one through the pandemic begrudged the work of the NHS. No one in the care sector begrudged that. But I know colleagues in the care sector have reflected that people applauded the NHS. They brought pizzas and coffee for NHS staff. They gave NHS staff discounts in supermarkets and so on. But no one in the care sector got the same recognition for doing, hugely harrowing work, particularly in care homes, under very, very difficult circumstances. I know, having been out to talk to colleagues working in our own in-house provision post-pandemic, I was moved to tears really by their stories of actually how difficult the circumstances have been and not recognised. But James, I know that the care associations across Yorkshire and Humber through the call to action are working with ADAS to kind of understand more to kind of regional level what we can do about, particularly about kind of supporting the workforce.
Yeah. I mean, everything Richard said is correct. I think the social care workforce is a bit of a Cinderella service. We've been treated in that way for a long time. I got to the point where I've talked about being the mice at Cinderella's table, not even Cinderella anymore, and that's how far down the food chain social care is. And yet, the reality is, without social care and the work that we do, the NHS, if it isn't crumbling already, is certainly going to go completely. And there's a real issue for me in that dichotomy of seeing the NHS as being the most important bit and the funding that goes with that, and that the local authority are underfunded to support the social care sector constantly. Just picking up, I suppose, on the workforce bit. Specifically, there's something in the fact that if you work as a healthcare worker in the NHS, you'll be on average over a year earning about £8,000 more than someone doing the same job in the social care sector, and in between that is the local authority, so the statutory sector will be sort of halfway between there possibly. And again, there's real issues for me around social justice. We've got, Michelle mentioned the fact there's predominantly a female workforce. I wonder if that's some of the reason why we get away with it. I don't know whether maybe that's a bit contentious, but I think there might be a little bit of something in that. But what are we going to do? And I think it is a national issue, but what can we do locally to actually start to readdress that balance, so that our local people are respected and rewarded for the job that they do, looking after the most vulnerable people in Kirklees? It's a big question, but I think it's, and I know, to be fair to Richard and his colleagues, we are in negotiations. We're trying to work a way towards that, but of course without improved funding from the nationals, from the government, whichever colour that is, going forward, we're going to be in this state for a long time. And I think social care is on its knees.
Thanks, James. Does that answer the majority of the...
Yeah. You're just saying what, we know, and I know there's no easy answers, and I wish we could give you a few £1 trillion to sort it out, just for the sake of all the old people in this country. It just feels, like you say, unjust, immoral. But thank
Is that okay? Does that answer? I think the last question Karen's just sent me, we think it's to do with the grants that's given to Corn Valley, not the...
Okay, it just came across as if applying for funding for the place people who were funded, that the form was actually quite lengthy as well. That's all I was raising.
Yeah, I was going to suggest that perhaps if it's something more nuanced, we'll pick that up afterwards. And thank you very much for raising the point about the difference between health service staff and between social care staff. I think that's really interesting. And pretty much like everybody on the panel, we'd all looked at rates of pay for not, it isn't just about making people feel as though they're trained and wanted and such. It's about pay. And I did the comparison as you would with Aldi, and came out that Aldi at the moment are recruiting at higher levels of pay, which is concerning. I can see that you want to come back on that.
Just picking up on the younger people and the link with schools, we have done some work as an association with going out and doing some careers work with some schools, and we're about to do a workshop with younger people returning to work, and working in social care is an incredible place to work. There's great value, you can get great reward from it. But actually, when it comes down to it, the question we were asked by everyone is how much to get paid. What's the career pathway? What's the pension like? And that's when, as someone working in social care, and particularly in the independent sector, it becomes a little bit embarrassing, to be quite honest. So going out and doing all of that work, because that's questions coming.
Okay, all right, thank you.
We've also got an ambassador scheme that was set up with Schools for Care, for domiciliary care, to go out into schools, which has been useful. We haven't done any of that work recently, but it's something that we're hoping to reinstate. And I would say as well, we've been quite good linking with the universities, where we've been able to get students doing the nursing degrees or the social work degrees who will come and work for us part-time. That's been useful. And certainly students doing A-levels who hope to have a career in medicine have also come to work in the sector, more so in daycare and children's services, I would say. And that's been good experience for them, and also given us some very enthusiastic staff. So it's been a bit of a win-win.
Alison, thank you.
Hey, can I just come in on the last thing, just discussing, because do you actually, how schools, say for example comprehensive schools, when they do their 2 weeks out, like for example my daughter went to work in a care home and she absolutely loved it. She did it with a friend, and all the elderly people who went really responded to her, and she just said she loved it so much. So I just wondered if we could perhaps do more of that linking with schools when they do those 2 weeks out.
This is work that used to happen quite regularly, pre-COVID, and I think it is something that we need to do again. And we've certainly had people come on work experience to work with. We support people who have learning disabilities, and it's been a great experience for them as well as for the clients to meet people. And I think it does just change people's perception of what the job is. And we have young staff there also that can talk to people about their journey in care and the career progressions that are available. And it is just about raising that profile. So even if somebody comes to have a look at the work that we're doing and doesn't want to work in the sector themselves, quite often, they at least leave with a increased impression of what the service is and what the work is, which is important too. I mean, we have recently been working with the Job Centre, who had a scheme for young people to come and have a look at our service and the type of work that we were doing, and it was mainly as well for them just to have an insight into what a career in care could look like. And from there we have actually recruited 4 people who had never considered a career in care. So that was actually set up by Intercare Kirklees for us, and I think they're going to go around other companies and other settings too. But we found that really, really helpful. And the real I will stop talking. The real bonus from that is that some of those people that we've recruited have referred friends. Great. One person in particular has referred 4 people. I think she's going for we have a £50 bonus for anyone that we recruit that you recommend, and I think she's going for that.
Sorry, I do apologise about that. Anyway, so my question's around the policy background and context. Insofar as you talk about care at home services supported by investment into housing opportunities, such as extra care housing and bungalows. And then I think, Rich, you referred to, or you mentioned a higher number of young people in care homes who you see moving into these type of bungalows. So how realistic is that, when we're in this situation where building materials have gone up exorbitantly, we're in a cost of living crisis, and where is that money going to come from to build those homes? How many do we already have in Kirklees? How many are planned to be built in Kirklees? And when are they going to be built? Thank you.
So I think it's important to recognise that we are investing in supporting those people, whether we effectively invest in it through revenue cost, which is paying the costs of often an out of area care package, or whether we invest some capital around the premises and then invest some revenue in terms of the support they get to be in their own home. So whatever happens, there's an inescapable cost to supporting people, but of course it's the right thing to do that in a way that offers high quality outcomes and support for people. So we've done a piece of work. We've got a principal OT who's an expert really in kind of housing design for people with disabilities. We've got a bungalow design scheme now. We're looking at a number of the small plots of land that the council owns, often things like former garage sites and so on. So we're not talking about building a housing estate with 200 bungalows on it. We're talking about much smaller scale developments using a very standardised design of bungalow, which is fully adaptable but actually will feel like a really quality environment to live in. We've got 2 extra care schemes under development, so one in Kenmore Drive in Cleckheaton and another Ashbrow. And we've got a specialist accommodation board within the council that's looking at demand and kind of opportunities for development, some of which is speculative. We have some providers interested in developing schemes in Kirklees. Some of that is part of a conversation with particularly with care homes colleagues about opportunities for diversification, and some of that will be actually about working with our NHS colleagues to say an intermediate step might be about providing some of those residential services within Kirklees rather than being out of area, in order that we can then develop more bespoke solutions for people. And of course we have the development Mayman's Lane, which is a very specialist housing development for people with very complex needs who previously were living in hospital settings. So we have got a number of those schemes. They will inevitably be of comparatively small scale, and it will be an extent taking opportunities. And whilst the capital cost of building has gone up, we need to recognise that someone will be carrying somewhere in the system the cost of where someone lives. Well, it's just whether we pay that through a weekly care fee or whether we invest in that ourselves.
Thank you. Because I just wanted to. So, are there will there be age restrictions on those kind of people living in those homes, or will they be able to live there into their old age, or?
So we know that kind of getting the mix of people living in a scheme is right, and if you're in your 20s, it might be really nice to live in an extra care housing scheme that's predominantly got people living in their 80s, but I suggest probably people in their 20s will want an environment that feels more like we're living with people of a similar age, which might take us into some of that smaller scale bungalow development, or some of the other kind of housing schemes that we know we will bring along. I think extra care housing will work well for potentially people in their 50s with a long-term disability, particularly where the housing scheme is well designed so it doesn't feel like you're living in a large building. And this is about, we all make decisions about where we want to live and the neighbourhood that we live in, and so that'll be about that set of conversations with individuals about what's going to work for them, recognising there'll be some compromise, but actually that compromise, many of us move house at a number of points in our life, and so actually maybe a bit about moving into a setting that brings you back into Kirklees. It's a bit of a compromise, but it's a good halfway stage, and then actually people will move again after that.
Thank you.
Thank you very much, Alison. I know certainly it's one of the things that's raised with a lot of our councillors about the bungalows that are already out there and the fact that there is no age restriction on those, and we've ended up with kind of a lot of antisocial behaviour next to what used to be. So I think that's perhaps where your question is coming from, about how we protect those areas. Kim?
Hi, my question was around the provision of equipment, really. Thinking about the Home First approach and packages of home care, you've made it quite clear that there's minimum waiting list, but I just wondered where we stood with people who are assessed maybe by occupational therapists need specialist equipment, especially thinking about people that staying in hospital maybe unnecessarily that are having waits for this. I just wondered what the barriers were, if there are any, and how they're being addressed, and what the kind of waits were around that area.
Thanks. I think Saf's going to take this.
Thank you. Yeah, so I think one of the things that we're seeing, and I described that we need to look at the service model in the current operating context. One of the factors that we're seeing now is that increasingly the profile of people, particularly those coming out of hospital, is more acute, it's more complex, really high dependency. And I think there's lots of opportunities to look at what's the best practice sort of provision around equipment that supports the whole ethos that we have around maximising independence. We have lots of really good therapists who provide some good input. I think the acuity is causing some pressures around the provision or availability of equipment and the timeliness of that equipment delivery. So we're trying to maximise the opportunity we have through the council's contract with the equipment provider, Mediquip. So really getting the best out of that contract. But what we're finding is that as more and more people are supported at home, the requirements for the more complex equipment perhaps is getting trickier, it's getting harder to source. There are supply chain issues that impact on that nationally as well. So yeah, that's one of the issues that's potentially causing a bit of a bottlenecking area for us locally. But I think in the absence of a sort of national strategy or a national endeavour around these sort of things locally, we've made some really good efforts. And I think that's something to take away from here. And we see all the sort of numbers and measures pointing in the right direction, that we have more people going home rather than staying in a short-term bed, for instance.
So you say you've made some kind of local developments and everything. What kind of things are you doing differently that are maybe done elsewhere that makes it better for Kirklees?
Absolutely. Richard mentioned earlier the principal occupational therapist, and that's something that Kirklees several years back decided it would be a really good investment, and it's sort of shifting that narrative away from a medical model of care to really positioning that within a social model. And often I think previously the kind of therapy provision has been taken on within the NHS because it felt like that was the best fit. But more and more we're seeing that actually getting people back to their optimal levels, the usual levels of kind of independence, functionality within a home, requires that more nuanced therapy response, and requires a response that integrates well with the care provision. So we've got occupational therapists now that are part of our reablement service. They work hand in glove with our support workers, our care workers. They provide that kind of treatment plan, the therapy plan that the care workers then work towards in terms of the kind of treatment regime, exercise regime. And I think that's something that's quite unique, where other areas have started to look inwards in Kirklees, say, right, what are you doing and how is that impacting? And what we're seeing through that, for instance, with more and more people going through reablement in the home, we're seeing more people where their independence has been maximised. So we can share the numbers and some of that data outside of here, but we're absolutely seeing that things are moving in that right direction. I think the other thing also to add is that Kirklees really needs to shout loud about its sort of moving and handling provision, because we've got some dedicated, passionate and expert colleagues whom we've got a colleague right now as a team manager for our moving and handling team, who's actually advising and doing a bit of a consultancy role with Leeds City Council and the Leeds Health and Care Partnership. And I think it's maximising the best practice that those colleagues bring as part of their research, as part of the education, to think about what is that kind of latest equipment provision, what is the latest therapy provision that we can deploy in this area that supports all of the things that we're trying to do.
It's really useful, thank you.
Yeah, thank you.
Helen.
Thank you. Just to build on the thing about the reablement and sort of all the partners and things, it sounds like a fantastic achievement to have actually got to that point where there's very, very close working relationships. I did want to ask, sort of, because it prompted the question around how that works with the care programme and just for interest really about how that actually works together. But also, just I know it's sort of been a national issue around home care visits and the cutting corners, the not being able to spend as much time, cutting down. I wondered how much of an impact had we seen here in that, where agencies are just, and the stuff around travel time. I'll just get through my questions first. Yeah, you're reaching for your microphone. Hold that one. Yeah, just in case, in terms of have they had to be sort of shortened, or has that had an impact here? The things around the CQC ratings, for those who are not published ratings, because there was none on the care homes, but on the domiciliary care there was. Are we using those agencies? And kind of like that, just to be reassured about the ones that are under needs improvement, which also links me into a question that I've raised a couple of times before around the framework and the use of agencies that have either failed the framework or haven't applied to it, or they may be registered with CQC but they've not been inspected, and the use of that and how how that's operating. Because I think I've raised those concerns a couple of times. Yeah. Go.
I think there's a few things there then, Helen. I think I wouldn't mind inviting James and Karen just to talk through how we built the relationship and how we built the care association and what the partnership actually looks like now, and how we try and work together as a collective group of individuals, but also from a regional point of view, some of the regional work that James is heavily involved in, and so Richard and I. So I think that'd be helpful for you to hear some of the context of that, if that's okay with James and Karen. I think in terms of sort of
home care, there's lots of things that we are doing at the moment in terms of spot purchasing. We've got a new process in place where we will allow somebody to go into a spot purchase provision, but there's a process in place that will only be for a period of time and until, because what we do is we work with a local provider and we look at, you'll go on a spot because that enables speedy discharge, but as soon as there is capacity with somebody who's on the framework, then the expectation is that individual moves to somebody who's on the framework. Does that make sense?
And is that a set time that they won't stay any longer than, say, 6 weeks or something?
I'll bring Emma in on that because Emma's put the process in place, if that's okay. I'm just trying to put your questions into so that people know what they're answering. And the other one was CQC ratings. Yeah, around the non-published and published, which we can answer again. Is that the three? We're at a certain age, Helen, who goes in and comes straight back out.
Sorry, I wrote them down. Nerdy, yes, I am. There's one about time delays for home visits.
Oh, yeah, 15-minute calls. Emma can take that. Yeah. James, do you want to start and then Karen chip in?
Yeah. Been official for the last year, but we grew out of the COVID situation, really, out of the pandemic, and the need. It became apparent that providers needed to be much more involved and engaged with our other partners. I think for many years, I think it's fair to say we've been done to rather than worked with. And so we were trying to change that as the providers, because we're providing services on behalf of the council to meet their statutory duties under the Care Act, and without us, they wouldn't be able to meet their statutory duties. So that's the reality. So working, how could we work better together, and how could the independent sector, remembering there's almost 200 providers in the independent sector who are small, medium-sized businesses, how do we engage all of those people? And that, lots of those businesses, like GP practices, like pharmacists, don't have the resource to be able to get involved, to turn up to meetings, to do all of these things. So we looked at how we could better do that, and a group of providers sort of got together really during the pandemic. We had support from the council, who have given us a small grant to start to build the association, and so we've only been around it for a year officially. I've been around a lot longer than that, although I don't look old enough. I know, I get that. But we both locally we're doing a lot of good work, but regionally as well. I think just mentioned the regional work we're doing. With the Yorkshire and Humber Care Alliance, we're doing a lot of work around workforce, working with ADAS in partnership with them. We've got a call to action group that we meet regularly once a month, and then every 3 months we have a bigger meeting where councillors from across the region come to that, and we're looking at trying to utilise the different strands that we've got. I think it's fair to say that there are things that ADAS and the local authority can't say. They're in a political world, but there are things that we can say because we don't have that same constraint. So I think between us, we're working the way that we can lobby, if you like, nationally. We talked about the national issue; it's massive.
Can I? Sorry to interrupt. Can I just ask you what the sort of achievements are to date, and kind of like what when you said you're working towards things, kind of like just to try and put it into
that's fine.
Practical. What have we got as a result, sort of thing? I get that it's a massive agenda.
It is. I think probably the biggest thing is engagement. That actually the providers of services are now involved much more in the development of those services, and I think that's a real is a big change. So that as well as the people receiving services, the people who are providing them hands-on have got a much better idea of what that service needs to look like, how it needs to look. We've done a lot of good work around workforce. There's still the elephant in the room. We've already mentioned it. But that pay and conditions are a massive issue for the independent sector. Just linking to that. Saf mentioned about acuity and the needs being much greater. That's absolutely the case, both in community services and in care services. But we're still being paid the same amount of money as if that wasn't the case, if you know what I mean. So there's issues around how we're actually funding that, and that's a lot of what we're doing for the independent sector. And we also represent some of the voluntary sector and the voluntary and community sector enterprises as well, because they're also providers of services, so they're members of our association as well.
So are you part of the care sector programme board?
Yes.
Right, you're both part of
Yeah,
that.
we've been invited to be on that as well. Yeah.
Helen.
Shall I hand over to?
Yeah,
Sorry.
and I think before I hand to Karen, I think it's fair to say that James and other members are key partners on lots of strategic meetings and decision-making boards now within the council, which they would not have been 12, 18 months ago. So they are part of ICB meetings, Kirklees ICB meetings, where decisions are made about funding. James is at the table with us making those decisions and hearing all of that. Which is great progress, I think, as an association, but also in terms of that partnership.
Yeah.
Thanks, Karen.
Yeah, so the Kirklees Registered Manager Network has been well established even before COVID, but came into its own during the pandemic. We have a WhatsApp group, and it was just going off into the, late into the night with managers asking questions. We were able to share the good practice guidance that was coming out, and also talk about how to apply it. If we had issues, particularly all the barriers just came down with Kirklees Council. So literally I just got to the stage where we were just emailing, Emma actually, to say, this is an issue, can you get us masks? How can we get funding for the aspirator generating procedure? Do you remember all of that one, Emma? And when we've had issues with getting equipment, we were sharing them between us, but also we were getting them from Kirklees. So we were actually really, I think, truly working together at that point. We've also been able to deal with training issues that we've had, and we worked closely with Locala, who have helped us with training for stoma care, things like that when we've had any difficulties. They're working quite closely with us now because we've got quite a lot of service users coming out of hospital who have got more complex needs, and some of the providers in the network are fairly new to these procedures. So rather than everybody learning everything from scratch and reinventing the wheel, we have put a group together of registered managers in Kirklees where we are designing our templates. We've done our first one. It's about to be hosted on the Kirka website, and our Locala colleagues have quality checked those for us to add some comments that they've got and to make sure that we've got them correct. So, and as part of that as well, we've also detailed where providers can get the training from, so that everybody can have a really good start at providing good quality care, especially in the more complex tasks. We are setting up some quality workshops with Kirka at the moment. We ran some of these pre-pandemic. They were really good. If I was to show you our WhatsApp group, and I'm happy to do that, it's fantastic. We really are sharing good practice from neighbouring authorities as well, and answering questions with each other. And it just makes it a much more joined up team. And I think any registered manager that you talk to in Kirklees who's part of this group will say that. A lot of the new providers who haven't had a CQC inspection yet are in the group, and I think they are benefiting from the knowledge of the other providers. We're happy to share resources, we share policies, procedures. Even during inspections, we're sharing things across to each other. And actually, the CQC inspector knows that, because I was talking to her the other day and she said, "Oh, thank you for everything you've done in the network. I know that you are sending across policies as we're inspecting." I'm thinking, ooh. but you can definitely see that, all that teamwork that's going on. And if we've got an issue, if we come across a provider who will say, "I've been commissioned to do a 15-minute call," which happened, I just raise that with Emma and it gets addressed. And we have addressed any issues like that. And so most calls now aren't 15 minutes, are they? And if they are, we can raise it with the council. And I think for me, this is a massive breakthrough now. I feel that we really can talk honestly about what our issues are. We might not always like the answer, but at least we have been listened to. And I think that is what, the biggest part for me is that I do feel we are listened to, and if we can be helped, we are.
That's really reassuring to know that you've got a voice at the table. That's great. And all part of the integration stuff.
Yeah, thanks both. Do you just want to finish off with Emma, just to give you some of the technical aspects of how we do things? Thanks, Emma.
So with regard to the spot contracts that you mentioned, just to let you know that that's actually reduced by more than half over the winter as the use of that, and now forms less than 10% of all the hours in domiciliary care. And that was as a result of our previous contracts coming to an end, and has been able to then look at how work was allocated on a more sustainable basis. We have been working with those providers to try and get them onto the frameworks as well, so that's also happened. Just to assure you, when we talk about providers who haven't been inspected, that doesn't necessarily, the CQC still go through a range of checks before they accredit them in the first place. So as the regulator, they have still been checked. And the CQC now work on a risk basis, as do we as a council as well. So we're constantly monitoring, pulling and sharing intelligence together. And that then informs how they prioritise who they're going to inspect and the order in which they inspect. With regard to kind of travel time, we've been moving away, no, sorry, not travel time, the short calls. We've been moving away from times and tasks and trying to give providers and service users and their families the ability to negotiate kind of what works for those, so they get like their hours over a week or over a 4-week period, and so they can combine calls or do things differently or use those more flexibly to meet their outcomes. But that's all still monitored through the electronic call monitoring data.
Can I just come back? Yeah, thank you. So in terms of the spot contracts, of the ones that you're still using, how do you inform service users of that sort of status that's different to the, because are some of those ones that have been through the DPS but have failed, are there any on there that have done that's happened?
I think it depends what you mean by failed. Sometimes, so
okay, so they've been through it and they've not been put on the.
That's usually so.
That's my terminology. Sorry.
Yeah, that there should be none on there that are causing us any areas of concern. But sometimes people don't pass through the DPS because they haven't submitted the right documentation, or they haven't got the requirements that we currently require. So they might not have like the financial standing or that sort of thing. Does that make sense?
Sorry, just they might have not have things like electronic call monitoring and things like that.
Yeah.
So would you keep using them though for a long term?
We shouldn't be doing, no. They should be being moved off.
And is that with a time span now then? Is that with a date?
Well, as soon as possible, but no, we don't actually have a time scale because it depends why that package was difficult to place in the first place.
Okay, I think Richard just wants to just come in just for a minute there, and then we're going to move to Vivian's questions, if that's all right. Sorry.
So, Chair, I wonder whether it's worth us coming back and having a bit more of a conversation about this and direct payments more generally, because of course any person using services is entitled to ask for direct payments and use that money to go and work with any provider or employ a PA directly, because actually the choice of provider is someone's fundamental right as long as they kind of meet a certain level of quality and they're CQC registered. So there's a bit about the role of the council in all of this, but I think a bit about the role of choice and control for individuals, and I wonder whether we bring all of that back into a kind of separate conversation, cover off this and direct payments more generally, because generally that's how people, if people can't through the council get access to the provider that they want to use, they will request the direct payment as their right and then go and spend that with the provider that they wish to use anyway.
Okay, all right, well thank you very much, thank you for that answer. Vivian, have you got any questions that you want to pick up at this stage? Unfortunately, we can't hear you, even if you have.
Can you hear me now?
Just.
Thanks. No, I've no questions. It's been a most informative discussion.
Thank you very much, Vivian. I hope you don't mind. Just a couple I think we didn't pick up. One, I don't think, I think within intermediate care, you talked about average demand being 48 beds and we've got 50 beds. Did you tell us that you're reviewing the intermediate care bed base again? So, you know, because obviously average demand means 50% of the time you're on, and that could cause delays. So we'll look forward to seeing something perhaps again about that. And you talked about social work vacancy levels. And it would be interesting just to understand a little bit about potential delays in moving care on or assessing for care needs around social work. So I don't know who wants to pick that up.
I can take some of that, Michelle, if that's okay. So with regards to intermediate care, Chair, yeah, absolutely right. Be happy to bring that back here. We had an aspiration locally. It's not something that's been driven by commissioners, I must add. Some commissioners haven't come back and said, can you reduce to a set number? It's an aspiration that we've set locally across Local and Kirklees Council. So we'd be happy to bring something back. But we are mindful that given the current challenges around managing demand, perhaps any further reductions might create a bit of a pressure point for our acute hospital partners. So we're being quite cognizant about that. Equally, we're doing a piece of work around if we take one patient or service user away or divert them away from a bed-based solution, what's the support that they require at home? What's that going to look like? And is that going to need some additional investment? So there's a piece of work that we're doing with the ICB, the commissioning board, on that during March. So happy to bring something back in the early summer with that. With regards to delays across social work practice or social work capacity, I think there always is, and nationally it's an issue in terms of that mismatch between demand and capacity or demand and supply. I think we're seeing some good successes in Kirklees. There's still a long way to go. I think as part of all of our recruitment activity, we're mindful that this is an opportunity for the council to promote itself and use that as an opportunity to really promote its values. So a lot of the stuff that we're doing right now in recruitment activities based on that value-based recruitment. We've also responded to understanding the variation between what are the pay rates across Kirklees compared with some of our regional councils or regional authorities. So we want to be competitive as a local authority employer, and we're looking to also address that in the right possible way. So we're attracting the right talent and the best talent within this area. We still are carrying some risk within our caseloads, and I think that's something that our principal social worker will have an oversight of. So we have a quality assurance framework that oversees what good practice looks like, what risk looks like, and we're actively monitoring and responding to that. But if that's something that the committee would like us to do a deep dive in, again, we'd be happy to bring something back here.
Thank you very much. I think we've had a really, oh sorry Liz, do you want to?
I can't observe, I just can't. Just really quick. Yeah, so you're talking about complex care, more complex needs coming out of hospital. And we don't have as long a wait time as other areas for coming out of hospital into care. But do we have any backlogs because of that really complex nature, in that people are in the wrong place because they're waiting for that those complex packages to be put in place? And he talked about care and packages for people coming out of hospital, but what about for people who are trying to stay in their home and they need their home adapted in some way? Are there bottlenecks in that area as well? Thank you. Really quick.
Just going to take.
So nationally, the kind of narrative about adult social care feels like it's one about the role of adult social care to discharge people from hospital, and that's very, very important. And there's probably 100 people today in hospital who will need some sort of social care support to get them out of hospital. But we're supporting close to 10,000 people to live a good life in the community. And so one of the things that's happened is, I think, both the narrative and the potential deployment of resource has got distorted. We are in a position where, because we don't really have a home care waiting list, we're not juggling, does someone get a care package in order that they can get out of hospital, but somebody who needs an increase in care package to remain safe and well in their own home doesn't get that because we don't have enough hours in the system. But there are a number of bits of the system that we know are under pressure in order, as people live with more complex needs, both to keep them, as you say, Councillor Smedger, in their own home through adaptations or greater use of technology and equipment, more timely access to, we know if you're living in your own home with a long-term condition, you're on an NHS waiting list, that's going to compromise your independence and ability to live independently. So we know there's a number of pressures across the system. And in terms of acuity, the risk is both about an increased volume of care, but also, as Karen and James have said, the ability to recruit and support a workforce that feels equipped and confident to deal with that increased level of complexity. And that ties back then into the conversation about pay and the broader reward offer, which is actually, if we're asking people to do ever more complex work, and people are up for that because it's the right thing to do, and we're asking them to do ever more training, but we're still paying them less than you would do to stack a shelf in a supermarket with a lot less training required, that feels increasingly, as people said, unjust. And what we also know is about people living with more complex needs is that there's much greater fluctuation in terms of levels of demand and the level of risk, so potentially more frequent requirements to go back and review that, greater need to support family carers because they are inevitably supporting people with kind of more complex needs, and even greater importance of that sense of feeling integrated from the perspective of an individual and their family in terms of that join up between kind of NHS and local authorities and care providers. So it's not that we're in a position where we don't have the care, but the challenge is to make it feel really, really joined up for people, and that does feel increasingly complex and difficult.
I think by the questions that we've been saying it for a long time, health and social care is one system, and if one part is under stress, then the other parts become under stress as well. And I think it is very, very clear is that. Thank you.
Thank you very much. I'm going to wrap this part of the session up, but I think what you've very clearly articulated is how difficult the environment is within which you work, and we have heard a number of really good practices that are coming out from the services, so I think thank you so much for that. We will follow up on one or two things where you've offered to come back on things, but I think we've all felt that that's a very beneficial session. Thank you. We will take a short break just now, just until we've moved people over. Much.
Thomas second.
Yeah, are we okay? All right, so we are now live. So welcome back to the meeting of Health and Adult Social Care Scrutiny. We're coming to our agenda item about dentistry, and I'll be honest, the scrutiny panel are very interested in dentistry. We're very keen to have it back in Kirklees' site or lens, if you like, and we are keen to be sure that the transfer takes place and that what flexibilities there might be once it has taken place to improve the oral health and dental care within Kirklees. So no stress then, Debbie. I think you're presenting this, aren't you? And I know we've got a number of people that are supporting you. Can we ask that when it's your turn to speak, if you introduce yourself, and then we can make sure that the public are aware of who's here. Is that all right?
Okay, so my name's Debbie Stovin. I'm the Senior Commissioning Manager at NHS England for the Yorkshire and Humber Dental Commissioning Team. So a paper has been circulated. So if I just go through the main points of that, and then obviously any questions can be fielded by anybody who's part of this presentation really to the committee. So there's within our paper that we've submitted, it just provides some background in terms of the range of dental services that we do commission from NHS England, from high street dentistry through to secondary care specialist services. We've got 50 practices, primary care practices in Kirklees, so that's that's your high street dentists really. And they're all commissioned on various levels of activity. We do commission on units of dental activity for these contracts, which is based on courses of treatment. So the more complex the treatment, the more units of dental activity that accrues. Our responsibility really from NHS England is remit for commissioning of dental services. So other parts of oral health fit with local authorities really with their statutory responsibilities around oral health improvement. So we're going to focus mainly on commission of dental services today. We just want to identify within our paper the key challenges that are faced within dental services, and an update in terms of an oral health needs assessment that was undertaken last year, and also some additionality we've actually been working on this last year or so. So we do have issues in dentistry, as you can imagine. We do have huge access issues at the minute across the whole of the country, and certainly we are experiencing that in Yorkshire and Humber. Some of that is linked to the legacy arrangements we have to contract dental services. So contracts from 2006 were a majority of those are in perpetuity, so they are contracts that are there and we can't change them unless we've actually got any performance concerns, or actually a contractor hands their contract back, or we wish to terminate a contract based on performance. Generally, when they do come back to us, we are able to do something slightly different and have that flexibility around procurement of new services, because what we don't then procure is services that are again forever contracts. We will put time limits on those, so we are able to then shape those around the needs that we feel are in that particular area. And we've got examples of that we've recently done in North Yorkshire and Humber over the last year. And we've not had any contracts handed back in West Yorkshire as yet. We do face quite a lot of difficulties from patient perceptions really, so I've just outlined a few on the paper there. So there is a bit of confusion around dentistry generally, so people assume that they're on a registered list with the practice, and that's not the case. Around private dentistry, we have no control over private dentistry. Many of our dental practices will have a mixed contract of NHS and private. Their private work is we have no control over that. Like I say, we commission their NHS appointments and their NHS activity. And we have difficulties at the minute. We've been going on for a while with practices being able to take on new patients or actually see patients as their regular patients. And part of that as well is linked to the internet, where we have the nhs.uk digital platform to help patients be able to navigate around practices. It's not always clear on there actually who's actually able to take on new patients and who isn't. And that's not a contractually mandated element within the 2006 contracts. Part of the dental contract reform is addressing that to some extent at the minute. COVID, just like any other health service and other social care services, has been a massive impact on dentistry. We had several months of practice closures early on in 2020 when the COVID hit, and they've been gradually increased. We are now up to 100% of activity with our dental contracts, where before it's been much lower because of all sorts of challenges regarding infection prevention control and being able to sort of patients accessing services. But we are getting through that, but that has created backlogs with managing new patient demand. Orthodontic contracts, we did undertake across the North region a procurement which was into following some regulations, and we've now got 2 specialist orthodontic services in Kirklees, one in Huddersfield, one in Dewsbury. Previously there were 4, and it may be that they we've had some practices didn't actually bid in this time round, or they decided not to continue with their orthodontic contract. Patients have been placed closest to the home wherever that has been possible, but I am aware that there are challenges in the system, and our commissioner and contractor for orthodontics is dealing with that. We've got some patients who are not at their ideal practice. Patients are asked to, wherever possible, attend their first appointment with their new allocated practice, and we've set up a separate appeals panel now to be able to deal with any that are appealing the decision of the practice where they've been allocated to. But we are trying to address those issues on a patient by patient basis through that system. The oral health needs assessment I mentioned, that was undertaken last year. We've put an outline in the paper for you, so you can actually see some information on there. And we are currently working on looking at place-based elements of that. We've worked them through to become, we've got ICB level reports, but our dental consultant colleagues are actually working at the minute on place-based to make that more meaningful to place, which we are just finishing and testing with one area and then looking to roll out to others. In terms of the dental system reform on page 4 of the report, we did the first changes, which were significant changes last summer that came into force, which is a change in the 2006 contract that we have for dentists. So there are some changes that have been made, and there's still further ones being in discussion. Some of these have meant we've had to have regulatory changes made to the contract. So some of them only just come into effect now, where others took effect a couple of months ago. So they've been phased in over the last few months. But ultimately, it's about trying to make sure that we are delivering care to the high needs patient, making it easier for patients to access care. In terms of West Yorkshire, and we have done this across Yorkshire and Humber, but in terms of West Yorkshire, we've had additional sessions within our dentistry services, high street dentists, and we gave an option for any dentist to actually participate in this across Yorkshire and Humber. And it's a scheme running from November to the end of March of this year, using some non-recurrent money we had. And this is about trying to make better access for patients that have got urgent care or emergency dental needs, or that are actually presenting with a dental complaint. And this is about practices working in conjunction as well with NHS 111. So we can make more appointments available through the urgent care system, but also for practices to be able to receive patients and treat patients who contact them. Now, not all practices have actually taken up that offer. Obviously, this is about additionality on top of the contract. So some practices aren't in a position to do any more than they're already doing. But in Kirklees, we've had 8 practices that applied to do this scheme and now offering 24 sessions per week. And we expect 7 appointments per session as a minimum, but they are within core hours. These have gone very well. We're receiving really good feedback from different parts of the field, whether that's through our urgent care provider or from practices. And we are looking, but we can't guarantee yet what's going to happen after the end of March, because we are obviously, the delegation for dental goes over to ICB. So there's an awful lot of discussions at the minute with ICBs in terms of how we can move things forward. Another part of our additionality programme that we've been running, our dental developments, is trying to incentivise recruitment. So we've had identified through the oral health needs assessment a number of areas, and this is down at ward level, where they've been deemed as high needs areas. And we've contacted all those areas to make an offer to be able to help with giving a bit of an incentive to help recruitment. Workforce is a major issue within dentistry, and whether that's with dentists or nurses, but this is an incentive really for dentists where we have got a shortage of dentists. Again, that's affecting the whole access issue with dentistry as well, and one of the challenges that we're facing. But it provides a one-off payment for the performer coming into work in that area. So it's just a bit of help for when practices are trying to recruit and retain new performers, new dentists into the area. We did have a number in Kirklees that we identified in those areas, and we had one practice that applied to us that was eligible, and we're just waiting to see what the outcome of recruitment is for those practices. This again is open until the end of March. Some of them will obviously be maybe in recruitment processes already, or they've just not been able to recruit even with the incentive that we've provided. Flexible commissioning, some of you may be aware of what flexible commissioning is, some may not. This has been running in Yorkshire and Humber now since back end of 2019. So it came into force just before and obviously during COVID. So it was a bit of a slow start, but we've done an awful lot of work over the last couple of years with this. And this is about trying to improve access to dental care and increasing delivery of evidence-based prevention in primary care. And allowing practices to utilise their skill mix within the practice. We did an evaluation last year and it evaluated really well, and it actually proved that we can actually commission services differently and not rigidly around the units of dental activity within contracts. So we've expanded that out again this year, made an offer out again to practices. So we've currently got, and it says 5 on there, we had 5 and we've been taken on more through the expressions. We've just got another 2 that started in December, and another one I believe has just recently started. And I know one of the areas in West Yorkshire, sorry, in Kirklees, which was proving difficult to actually, with some of the restrictions we'd got in Calderdale, where we only had 1 flexible commissioning practice. We've now got 2. One's just recently been signed up to start that process. So we're hoping that will make some impact in a positive way with this scheme. Whether we continue this again and expand it out again, we've still got decisions to make on that. We're just dealing with the extra cohort we've got at the moment to bring them on board with this. Waiting list validation. We don't keep a record of waiting lists within primary care with practices. That is their responsibility to do, and they will all work slightly differently. But we did a piece of work again through some funding that we had to try and get a better understanding of what the waiting lists were and get some validation working. So a piece of work was undertaken to do that. And what we'll be able to do with that is help with the sort of planning and delivery of our future commissioning and service models where we've got unmet need, and actually just get a general feeling about what the situation is there with practices and see what we can do to support. Community dental services, and thank you, Lakala, for joining the call today. We have done a review last year, which Sandra and another colleague led on, and done a review of the CDS services, which are services that which provide services really for adults and children with additional needs and from vulnerable groups. The review's been going on over the last few months, and recommendations which will help then inform future commissioning and future design of the service. And that does actually include paediatric general anaesthetic patients as well, and other pathway approaches. And we can expand on that if there's any questions. There's just a section in there regarding Locala, which being provider of CDS services across Kirklees. Care homes, we know that care home coverage of dentistry is patchy and inconsistent. Some areas have more domiciliary care, domiciliary services than others. And what we identified that, and often services are done on a reactive basis with urgent needs rather than more proactive needs. There's a review going on within our team at the minute, looking at how we can actually work on that and what recommendations we can get to get a better provision really for dental care for residents in care homes and those that are housebound. So that is ongoing. I know you mentioned at the beginning regarding transition with integrated care boards, so our ICBs. Delegation does commence on the 1st of April. So they take over delegation, which includes responsibility and budgeting for dental from this time, and the whole of primary care, dental being part of that. There's a lot of work going on to help that process and to make sure it's as smooth as possible. For the actual, obviously, the responsibility for the commissioning of the services and for the team my team that I work in terms of supporting that process and working on that. I think it does pose both challenges and opportunities to the wider ICB, but I think also it's there to try and make deliver joined and responsive care really, and delivering high quality primary care services for the populations. And we're getting asked a lot more to produce information on ICB footprints and even place-based, which is going to take time to actually be able to get down to some more of that granular level. But there is an awful lot of work going on at the minute, and we are making sure they're fully aware of what the different challenges we are facing at the minute, particularly such as workforce and access challenges that we've got. The contractual framework as it is at the minute, it doesn't change. The contracts will be transferring as they are. So we've still got the same contractual challenges as we have currently within NHSE. But what we're hoping it might do is create more flexibility in achieving our ambitions to improve dentistry and access for patients. And making sure that obviously they can work with us to understand what the parameters of that are and how that flexibility could be utilised to fit future contract dental reform as well. So that's just a very whistle-stop tour really over the paper, and I'd like to open it to any questions.
Thank you very much, Debbie. I know that we've got quite a few from either LOCARA, Public Health, and from the Dental Committee. So yeah, we've got a number of experts here. So if we start with our questions and then we agree who's best to answer, is that all right? Can we, as councillors, I'm ever sorry because we've had another session beforehand, we didn't introduce ourselves. Just very quickly introduce ourselves as we ask the questions. So I'm Jackie Ramsey and I'm chair of this panel.
Hi, I'm Leslie Warner, councillor for Combe Valley. Yeah, thank you for all that. Quite a lot to take in. I suppose there's a couple of basic questions first. Do you have any figures for how many people are actually waiting for a dentist? You refer that there's no evidence, but there must be a central place where people are ringing up, or evidence from hospitals that people are having to go to get tooth problems dealt with because they can't find a dentist. Because there's a lot of signposts and things that you're doing, a number of practices, but I don't see screaming from the pages. Maybe it's just because it's diplomatically written that we have an acute issue with lack of dentists here. And I think, I mean, I was really pleased to read that amongst asylum seekers and refugees who actually can offer, you know, some major challenges in terms of oral health, they do get access to, which must also be putting pressure in certain areas. But at the same time, I read things like pay more for you get paid more as a dentist for 3 fillings. Well, when I was a child and going to the dentist, it was about prevention. And I'm guessing that preventative oral care is a bit down the way at the moment because there aren't enough dentists that people can access when they've no problems with their teeth. Am I wrong in this assumption?
if I just answer the first part, we don't have a central list. There is no central number where patients will ring needing access to a dentist. Patients will contact one or more dentists themselves to be asked to be put on a waiting list or ask for access to have an appointment with a dentist. There's no central telephone helpline or anything like that in dentistry. That was part of why we undertook a waiting list survey, just to understand what the current lists are that practices are keeping. Some do keep lists, some don't, but actually to try and gauge a level of the waits that people are experiencing. And obviously with the NHS.net, sort of what was choices, as people might have commonly heard it before, they can look on there to actually obtain the dentists that are in their areas, because you can put in an area and it will bring up all the dentists in that patch. But there's no central register, I'm afraid, to actually capture that level of information. So it depends on UDAs and then the prevention. The more complexity of treatment means that there are more UDAs attached to that because it takes longer, it takes more time. However, prevention should be something that's dealt with in every practice, but the flexible commissioning scheme we have is very much focused on prevention, and we've been opening that up wider to other practices. Sandra, do you want to add anything else regarding flexible commissioning?
I was just going to ask you if you had a ballpoint figure of how many dentists you think we're short of in Kirklees. Would you have any idea how many you think we could do with?
I can't give you a ballpoint, no. I would have to look back to see how many practices actually applied to do what we've termed as the golden hello, the incentivised payment. That would give us an indication of how many vacancies we're having reported that would want to be part of that scheme. But that would be only at certain parts of Kirklees. I haven't got that figure with me today.
Can I just bring Sandra in? And I don't know whether you're... Sandra, do you mind introducing yourself when you come in? I don't know, Matt, you're a practicing dentist, aren't you? Whether or not you've got any input you want to put in.
Yes, good afternoon, everyone. So I'm Sandra Whiston. I'm a consultant in dental public health, working for NHS England. And yes, I am a dentist by background, but I'm a specialist in dental public health. And in terms of, first of all, the flexible commissioning, the one point I was going to add to what Debbie just said, flexible commissioning offers practices the opportunity to work in a more holistic, prevention-orientated way, and it offers them the opportunity to use skill mix to deliver much of that prevention. Because, you know, we know from other schemes we've run across Yorkshire and Humber and nationally that much of the preventive care that patients require can be delivered by what we call dental care professionals. So that's therapists, hygienists or dental nurses. In terms of the how many dentists we think we know, part of a piece of work that's going on around the waiting list validation, we've also asked that question of all the practices about the level of vacancies they're carrying at the moment. So at that point, we should be in a better position to know what our workforce capacity is. But to date, nationally, there's never been, well, either locally or nationally, there's never been a dental workforce survey done.
Thank you. I don't know, do you want to add anything, Matt?
I suppose it's kind of what you want me here for, really. So there used to be a list held going back a long time, probably perhaps before Debbie was working for the area team. But I think the cost of administrating that waiting list and also the size of it meant that it was then no longer held. So nobody knows how many people wanting a dentist, might be the cynical way of looking at it. But in terms of prevention, the current contract is sort of part and parcel, but it's not actually attributed to any UDAs as such. So as an NHS dentist, when you're quite busy, the bit that you try to do as part of your service, but the bit that isn't actually paid for, is the prevention side of things. So that is not optimal. There are issues with the 2006 contract. I don't want to sort of paint too bleak a picture, but the reality of dental, or of running a dental practice currently, is I've got a mixed practice, and the reason it's a mixed practice is because I would say that anyone who's fully NHS with no private work is probably going slowly bust, because it's been an underfunded service since 2006. It's gone up by a below inflationary rise since 2006, and amongst many other things that have occurred over that period of time, and COVID and other things, it's probably as bad as it's ever been in terms of trying to provide that service. Now, we do it quite successfully. It's helped by our practice being closer to Leeds, because I'm in Batley rather than in Huddersfield. And with any workforce shortage, you can sort of fill up closer to the institution from as that sort of spreads out. So Kirklees has got a better chance than Scarborough, because it's very difficult for people to go to Scarborough. So it is a pretty bleak picture. The flexible commissioning and the urgent access sessions, I think, have been popular all round, but the funding of those going into ICBs is, as far as I'm aware, I'm not in any of those kind of meetings, but hopefully they'll continue. I'm not sure how many of the 8 that were mentioned by Debbie are kind of extra work on top of the contract, or whether it's a practice like ours where we are doing those sessions instead of the UDAs, because we've never not hit our contract in the 15 years we've been doing it, and this year we're really struggling. So we've had our contract, we've spent it on running the service, but if we don't hit our contract and we're outside of 4%, then we have to give 4% back, obviously, because we haven't used it, and that's quite right. But we also get a breach notice as well, and so that's sort of a broad tool, blunt tool that the commissioners use. But it's just getting harder and harder, and to keep dentists within the system is getting harder and harder. And so there's just this sort of tsunami of confounding factors that just make it very difficult for everybody. I mean, the commissioners, it's very difficult when there's a workshop sorted. I mean, I caught the tail end of the previous session. I'd imagine it's social care, education, everything. It's all the same. It's underfunded. There's not enough people. Yeah. So that's.
Kirklees Local Dental Committee. Yeah. Okay. Brilliant. Can we move on to questions, Alison?
Hello, thank you. I'm Alison Monroe, representing people in Almonbury Ward. I've got just 1 or 2 questions. So my first one is about dental therapists. What procedures will they be allowed to undertake? And dental hygienists, will they be funded as well by the NHS, because their work could be considered to be preventative? Then I'm moving on to government reforms. NHS dentists will be paid more for treating more complex cases, such as people who need 3 fillings. I didn't know a filling was considered complex, or even 3 fillings being particularly complex. So my concern here is it going to be a case of the government are going to pay for more fillings, but when it comes to more complex procedures, such as crowns, such as root canal, those kind of issues, is that still going to have to be paid for privately? And then I've got another question about in relation to the health equity audit approach that's currently being developed. I think this is essential to actually improving access for everybody. So I'd like to know, when is that going to be undertaken, and when will the results be published, and more importantly, when will it be actioned, basically? So just a few questions there. Sorry.
Who feels able to pick those questions up then from Alison?
Sandra, you're on mute.
Sorry. Shall I start with the first question about therapists and the hygienists? Oh, sorry, I've got an echo now. So under these new changes to the contract, so for a number of years now, under General Dental Council regulations, which is where all dental professionals, dentists, therapists, hygienists, dental nurses are all registered, therapists and hygienists have been able to undertake what we call direct access. But it was not permissible until just recently under NHS regulations. And that is the loophole that they've essentially removed. So it meant that a therapist or a hygienist could work in a private element of a practice under direct access, accepting their own patients. But now under an NHS contract, they can accept those patients. The one loophole, and maybe Matt can comment on this as he speaks from the experience of running a dental practice. The one loophole we have, though, that hasn't been closed by National is that we believe that therapists and hygienists will require patient group directives in order to enable them to prescribe local anaesthesia and fluoride varnish. And at the moment, we've got no guidance on that. So that's something that we are currently working on, and we're seeking clarity from National.
Shall we?
Wait, sorry, when you say that they will have, now the loophole's been closed, so they will both work under direct access, does that mean they will be able to perform procedures such as fillings? And then my other, just coming on from that, in relation to anaesthetic, I have had reports of NHS patients being treated for dental care for fillings, and they're not being given anaesthetics, pain relief for the filling when they're having the drill. Is that common practice? Sorry, I'd like to know the answer to that as well, please. Thank you.
So in terms of a therapist or hygienist has to work within their scope of practice, so it's what they're trained to do. So therapists are able to do simple fillings. In terms of the administering local anaesthetic, I am not a wet-fingered dentist at the moment, and I cannot comment on that. I don't believe that really people should be being treated that way. But again, perhaps one of the practicing dentists in the room might be able to comment on that.
I think I prefer to numb people up, because if they don't jump, then I don't jump. So it wins all round. But having said that, pain is very subjective. Some people, when they're giving birth, need an epidural. Some just, don't need anything. So is it? Are you able to do a fill-in without anaesthetic? Yeah, absolutely. On the right patient. Some patients prefer not to have any anaesthetic. If it's within enamel, then there shouldn't be any sort of there shouldn't be any nerve stimulation anyway. So if it's like a fissure sealing filling where you're having to drill out the fissure to seal it, then that wouldn't need any anaesthetic. But the problem with sort of anecdotal stories like that is you need to know the ins and outs as to why that's occurred. It's not always possible to get people numb. So I don't know.
I'm actually speaking from personal experience. It happened to me with an NHS dentist, and I wasn't given a choice. I was just told this is what's happening.
Okay, we might have to leave that one there. I don't think you got a response based on the kind of like what happens for complex care, and I do think there is an issue about equity here, in that anecdotally we understand that people aren't taken onto books where they may have a range of complex care that's that, you know, so it's easier to manage patients that you know and you know well and you know have had good dental care than it is to take new patients on that may have complex care needs. So that we might be looking at asking Catherine at some stage, once she's taken on Kirklees, understanding where we do feel that we've got the gaps in dental UDAs and where we're not getting that NHS provision. So I don't know if there's a comment anybody wants to make there.
Again, do you want me to come in?
I think we've just got Catherine in the room, and then who've we got? Oh, Balkeys. Yeah. So Catherine first, and then yourself, if that's all right, Balkeys.
Hi, I'm Catherine Wormstone, Director of Primary Care for the ICB in Kirklees Place. I think we've met before on a range of issues, including GP access, which there are some striking similarities, I think, with the challenges with access and workforce. So I guess from our perspective today, we're here as the receiving organisation, recognising, as Debbie's described, it's a fairly succinct process over the next few months, but I think in terms of the sharing of information and understanding in detail where some of the challenges are within our area, you know, are things that we're going to have to work through in partnership with our NHS England colleagues who've got all the expertise and the information. But I think it's something that we're really keen to get into some of the detail of, and particular questions like you've touched on today, some of the, you know, sort of complex access needs and the health inequalities, and making sure that we know we've had, you know, significant arrival of asylum seekers and you know, people who've got some of those more complex needs into the area. So that's a particular focus, I think, for us as well, making sure that they've got access that is as, you know, as good at least as the rest of the population.
Balkeys.
Can you hear me? Because I'm having to use my phone to actually speak. Can you hear me?
Yes, we can, thanks.
All right, brilliant, thank you. Yes, just talking about complex patients and those with high treatment need. We know that the current contract for NHS general dental practitioners is not fit for purpose, because you get the same amount of money to do 2-3 fillings on a patient as you would if they need 20 fillings. So it's not really financially viable for practices to treat those patients. In fact, sometimes they treat those patients at a loss to the practice, which obviously just doesn't make sense. So I think, and with patients who are medically complex on top of that, then who require, say, letters to specialists, and obviously a lot of these patients will fulfill the criteria for community dentistry as well, but many of these are seen in practice. They often require letters to their specialists, so it's very costly, and the NHS is not adequately funded to treat those patients. So you're always going to have this issue that those with high treatment needs, with very complex needs, you know, practice is not going to necessarily want to take all those patients on unless they're rewarded in the right financial envelope to treat those patients and make and sustain your business.
Thank you. I'm going to move the questions on, if that's okay. Kim?
Thank you.
Hi, just to introduce myself, I'm Kim Taylor. I'm one of the voluntary co-optees. I think you've answered my question, which was basically around what happens post-March around the urgent access initiatives and the extra sessions that are being offered to support urgent access. And I understand that you're in a situation where you won't know the future of that. I suppose let's just hope that they're able to continue, because obviously if they're not, then that will create even more pressure on a already troubled system.
Okay, I don't think anybody's picking that up on the basis that you've already had that answer. That's fine. Helen, have you got questions that you wish to ask?
Hi, I'm Helen Clay. I'm also a voluntary co-optee. It was just around the orthodontic service that has gone from 4 to 2, which seems quite a big change. And I wondered what's been the impact on patients, and has there been any consultation done around that in terms of impact, or, you know, what people preferred? It just seems to have been a pretty significant service that's changed fundamentally.
This was actually before I joined the team, but this was a service that had to be procured. We couldn't not procure the service, and it has been procured. It has been based on several what we've called lots across the whole of Yorkshire and Humber, and there would have been some work undertaken to understand the level of need across each of those areas based on figures that were available at that point. So there has been 2 specialist contracts in the system now, like I say, one in Huddersfield, one in Dewsbury. And patients, wherever possible from the previous providers, if they were already receiving treatment, have been transferred. The majority of those would have been transferred within the area. However, there will be some that have had to go to ones nearest to those as well. So some will have been placed outside of Huddersfield or Dewsbury practices. And like I say, we have, because of the volume of calls that we receive, and knowledge around the fact that patients have having to travel that bit further in some cases, then we are looking at trying to move patients wherever we possibly can. There is a huge need on orthodontic services across the patch, across Yorkshire and Humber. And that is another thing that we are needing to address. All our referrals for orthodontics go through a central system. So they go through referral management service, and all those then are available for the practices to be able to pull down referrals as and when they have a space. And at the minute, we are up against a lot of challenges for orthodontics, and we are aware of those challenges and trying to do the best we possibly can with what we've got. And like I say, we have got an appeals process that has been set up specifically to deal with orthodontics, to try and reallocate patients who aren't at the practice of their choice, and trying to make that practice of choice wherever we possibly can. There needs to be an understanding as well that patients may not want to go to the practice in their immediate vicinity, and that might be due to where their school is, where their parents work, access to be able to get to those practices. So some will choose to actually go outside of the Kirklees area on those basis really, and considering transport, etc. So we have still got some challenges in orthodontics, and we are trying to address them.
So does that mean that capacity is reduced as a result of, or is it the same capacity, just 2 different centres now, or capacity is reduced and you've got more people waiting?
I haven't got the exact figures to hand. It's not, orthodontics is sort of not my specialty area really. I would have thought, but I can check on that and feed that back into you if that would help.
Yes, we'd like that information if that's possible.
Okay.
I don't know exactly. Our area, actually the commissioning went through a couple of years earlier than the rest of Yorkshire and the Humber. And as far as I'm aware, it's pretty much the same, just spread differently. The main issue, just as background, with orthodontics is that a lot of contracts weren't held. So a provider that lost their contract in the tendering, quite a few of those didn't then move to work for the new person on the NHS. They went privately instead. So I would estimate that the number of orthodontic specialists in West Yorkshire perhaps reduced by 1/3. So each of the practices that have got a new contract, on the assumption that they might get orthodontists moving over to them with their new contract, they've got challenges now with workforce, which has been exacerbated. So there wasn't necessarily enough orthodontists anyway, and now quite a few have exited the NHS because their business didn't maintain the contract when it's recommissioned. I think that's fair to say, isn't it, Debbie? So that there's quite a few problems which are not ones that can be easily solved, I wouldn't say.
Okay, thank you. Do you want to come back? Okay.
Only just about the issue about consultation and the impact on patients as a result of this.
I can't answer that, I'm afraid. I will have to come back to you. As I say, I've not got that information. It was before I joined the team. This is going back a few years, and it's not something I was briefed on before I came. So I will find out about consultation.
Okay, Vivian, is there anything that you want to pick up at this stage?
No, Jackie, not at the moment, thank you.
Thank you. Can I just ask then from a Lacala perspective, what waiting lists are looking like at this stage, and what waiting times you've got around dental care, please?
Thank you. I do have some figures for you as well. So our waiting list currently for new patients is approximately 2 years. Now, this is taken into account that we have had increased number of referrals over the last 18 months. So it hasn't actually got longer. We have managed to keep it to 2 years because it was at one point increasing, and we recruited some additional dentists. It is actually very difficult to recruit those with experience within the community dental service. So we have given an opportunity for general dental practitioners to join our team and train them within our own service. So so for new patients, we have over 1,500 patients waiting at present, and it's the majority of those are actually children, and a smaller percentage is adults. We have the challenges we're facing is recruiting a paediatric consultant or specialist. We have advertised numerous times and we've had 0 applicants because there's actually a national shortage. We have had an issue with access to general anaesthetic for exodontia for children, which is, I think, one of the reasons why our waiting list has remained quite long. We're unable to treat those children. We thought we were close, but CHFD have a shortage of paediatric nurses, and they've had a huge recruitment drive, but because there's also a national shortage of paediatric nurses, we've been unable to restart our paediatric general anaesthetic list for dental extraction. So a large part of that waiting list is children waiting for dental extraction under general at Calderdale Royal. And we've lost our lists at Dewsbury District Hospital because of lack of theatre space and changes they've made, and we don't have any access to lists at Pinderfields either. So the only list we could potentially have at the moment would be at Calderdale.
Oh my goodness, thank you for that. Can I just
say that we are working actually very hard? I mean, I wrote a whole new process, and we actually had a date to restart those hospital lists, and then we were told by the hospital they didn't have enough paediatric nurses. So Leeds Dental Institute have helped us with the really urgent cases, and I have to say obviously a huge thank you to the Leeds Dental Institute, but they can't take on obviously several hundred paediatric. They don't have the resources, we don't have the theatre space. So some of these things are out of our control. We've worked very hard. I've been in post for 1.5 years, and I think this is the first time we've actually recruited quite a number of dentists, including 2 bank dentists, to help at least try and reduce those waiting lists.
Well, I think it was 2 things. Sorry, I'm getting a question from the side. One from CHFT was the fact that you're short of paediatric nurses, and the other one from Mid Yorks was the shortage of theatre time, was it?
It's not. Mid Yorks has given us no access to theatre lists, whereas pre-COVID we did have access to theatre lists in the Mid Yorkshire Trust. And we don't think that's going to change, maybe possibly up until 2024, 2025, we don't know. But we've tried very hard, whereas the CHFT are desperately trying to help us, but the pressures, because I've worked with CHFT to write a whole new process, and we did start assessing patients to be treated under general anaesthetic, generally the fit and healthy children who require dental extraction. but it was the shortage of paediatric nurses, and you do need them for patient safety. There is a minimum number you have to have to treat those patients safely.
So can I just check? This is something that's been commissioned by NHS England up until now. So it's a known problem, is it? But it's going to be transferred across to your team then, Catherine.
Sorry, it's probably helpful to clarify that. I know some of the team from NHS England are transferring over to the ICB, so we'll maintain some continuity and some organisational memory of the people that are familiar with the agenda. So that's, I think, where some of the benefits can possibly come about those local conversations with our trusts. So, you know, it's not just NHS England or Locala in isolation trying to have that discussion. That hopefully is one of the benefits, that we can have those partnership conversations and you know, make sure that it's featuring on the agenda with those conversations that we have with our trusts.
Well, thank you, Catherine. I really hope that as we get down to place, these are the kinds of issues that we can bottom. I can see that Sandra, you wanting to speak.
Yeah, thank you. Just to in many respects, to reiterate some of what Balkis has said, you know, this picture of recovery of our community dental services, but particularly the access to general anaesthetic services, is something that has become a major work stream as part of the CDS review. It's a very mixed picture across Yorkshire and Humber. We have some services that have been able to recover their general anaesthetic services fairly well. And then there are others where Balkis' service has the sort of almost like multiple whammies of, you know, there is, I understand, a national shortage of anaesthetists, the sort of operating theatre staff. Balkis has paediatric nursing staff shortages, and just generally getting access to theatres. You know, very few hospitals are able to give our community services access to additional lists, because I think often people think, oh, we can just throw money at this and we'll get rid of the waiting list. But if you don't have the staff, you don't have the theatre capacity, there's very little that we can do in the system. The challenges we have across West Yorkshire are already on the radar of the West Yorkshire Acute Trust, because myself and my colleague Sally, who co-led the review with me, we've already started working with the West Yorkshire Acute Trust, so they are aware of the issues.
Okay, I'm very aware that somebody else has wanted to ask a question, but can I just ask you, Balkis, what impact that is having on patients and what feedback you're getting from parents, please?
So clearly we have parents that are very unhappy. I think generally the ones that are getting acute pain, if they have multiple episodes of infection, then we are referring them on to the Leeds Dental Institute, and like I said, but they also will only have limited access as well. It's putting them under additional pressure. We do get increased number of complaints. I'm aware that some patients that have been waiting a while, they've actually gone to A&E because due for, say, a course of antibiotics, or because the pain has not been able to be managed. So, but we are working very hard, and our staff, including myself, are willing to work any day if we were given the theatre space, you know, where we are absolutely doing everything that's within our power, but there's things that are out of our control. So it is having an impact, because it means you can't reduce those waiting lists, because we're trying things like relative analgesia, you know, inhalation, sedation, but clearly that can also take a long time, and it doesn't always work. So they're just then back on the waiting list. We're trying, some patients we successfully treat because they've waited that long, they're more mature, that they're actually able to cope with local anaesthetic, and then we discharge them back to their own dentist. But there's many that still need a general anaesthetic.
Thank you, Balkis. Liz?
Yeah, Councillor Liz Smidge, can I just clarify that these are youngsters who themselves have themselves got a lot of maybe complex needs without the dentistry problem. But I'm wondering, if the scrutiny panel should.
Could I just clarify? Yeah. We are able. We're talking about more fit and healthy children. Those with complex learning disability or autism, we are still treating them on our special care dentistry list. So we are, in fact, the children that have very complex needs with learning disabilities or autism, they are actually receiving care under general anaesthetic. So we still have our Wednesday operating list at Coventry Royal Hospital. That's for adults and children with additional needs. But they are receiving care in a timely way.
Okay, that's great. Thank you for that clarification. But I'm just wondering if the scrutiny panel should write to the trusts and ask what the barriers are for this waiting list, and maybe ask the ICB as well to come back within a certain time frame to explain the problems that they've encountered once they've taken on the commissioning, and how the ICB can take this forward a little bit by working together with all the trusts in West Yorkshire. Thank you.
Thank you, Liz. Catherine.
Yeah, that is a conversation that I'll pick up with my colleagues, and I guess just wanted to reflect, just like the pressures on the community dental service and the NHS generally, we know that, you know, through various points in the last couple of years, the hospitals will have also had to prioritise their workload and their theatre space. So, you know, without going and getting a formal response, I think we need to acknowledge that position and the impact of COVID that there's been generally, and, you know, the very well reported winter pressures that the trusts have had to deal with. But I will seek at least to start that conversation in that partnership forum, because I do think that's where we can probably add some value to that discussion.
I think where we add value is picking up that discussion jointly with you, with the trust, so that we can write. Matt, did you particularly want to say something?
I was just going to say that these are not new issues. Several years ago, when the current CDO who was about to leave was doing her inaugural tour, this is anecdotal, but I had a patient who was maybe 6 or 7, had fallen out of a tree and had managed to spectacularly break in half 6 of his baby teeth. So every time he bit down, they flexed and they gave him pain. And the waiting time for him to have those removed by general anaesthetic was 12 weeks. To which the dad said that this is like a third world service. So these are not new issues, these are endemic, and with what's gone on over the last couple of years, it's just, yeah, and so it's gone from being less on the radar to very much on the radar, but the problems have been there for a long time.
A huge difference between 12 weeks and 2 years, but thank you for that. I can see we've got Helen wanting to come in. We will be drawing this to a close soon, so if you've not got over your points that you need to, think about them now.
Just a quick question, just to clarify, in that scenario with a child who's in pain, would the treatment be pain relief? So that child would only be prescribed pain relief for potentially 2 years?
Well, if you waited 2 years, they'll have exfoliated themselves, so you wouldn't need to do anything with it. I'm sorry.
No. What's concerning me is that this has clearly been a problem
for ages,
for a long, long time, and we're talking about a transfer to something else. And please forgive me, but talking about, oh, well, this is going to a different body, but the same people have been working on it for, I don't get where the average.
As far as I'm aware, I mean, I'm not fully cognitive as to where everything's going. So within my LDC, I'm still trying to work out what's happening and where. The line we've always been told is there are no new money. So there was money not being spent for various reasons, that then disappears back into the black hole. So that's gone because dentistry is no longer ring fenced. I don't know if the clawback money for dentistry is going to be ring fenced within ICBs or whether that's going to get lost in the ether. There wasn't enough money on the old system, and there wasn't enough staffing on the old system. I don't think there's any new money coming in unless somebody's going to tell me different. So I'm not entirely clear how things are likely to improve with those constraints. But I'm hoping that something might happen.
Matt, but Balkis, I see that you want to say something at this stage, and then I'm going to draw us to a close after that.
Going to respond to the question regarding what happens to these children when they're in pain. I mean, what you find generally, no one would be in constant pain for 2 years, and we do have a RAG rating system. And in fact, the Royal College of Surgeons also produced guidance during COVID on the priority of patients. So children with a very severe acute problem, such as trauma or a large significant swelling, there is a pathway even for those children to be treated with the oral maxillofacial surgery team, and also Leeds Dental Institute would help with those. Some do require, periodically require analgesics or a course of antibiotics, which is clearly not ideal. And some, as I said, have ended up in A&E because we find out from the families that they've had, say, a couple of visits to the A&E department, which is clearly not acceptable. And I agree with obviously Matt that this, there was an issue with insufficient access to GA exodontia, but this has been obviously perpetuated by the COVID and the lack of access to theatralists. Now, I do want to point out that CHFT have actually worked very closely and we've been in close communication, and that the only reason at present is the lack of paediatric nurses, and there is a national shortage too. So these are things that are very difficult to address within a few weeks. Thank you.
Thank you. Okay, I suppose just to draw this bit to a close, I'm sure we'll be talking dentistry a lot. Sorry, Catherine. It sounds as though we have got a range of different issues, workforce, funding, equity or inequity, to be more precise. Quite a lot of mapping out about where things are and where we actually need them. So I'm sure there's an awful lot. Obviously, this is an issue that we've agreed that we'll pick up alongside Catherine to see whether or not there is some scope for us to make a difference, to support you through work with the trusts there around the low car and the waiting list for community dentistry and children. But thank you again very much for attending. Thank you very much, Debbie, for presenting, and Sandra for being there. But yeah, lots to do. So much appreciated. Okay, thank you.
Thank you.
Thank you. Thank you.
We're just going to crack on with our bit of the agenda, but if you want to leave, don't you worry. We're not. We won't mind if you do it around us. That's absolutely fine. Thank you. Okay, panel. We're going to have a bit of a look at. Thank you very much. A bit of a look at the work programme, and just. A couple of things. I think the work programme is as it is now. To be fair, we've just
change it all for the next one.
we've just got the one more meeting. But in that meeting, we would like to spend a little bit of time looking at the review of the year and the end of year kind of report actions that we need for next year. So if you do have ideas, things that you don't think we've quite finished off, then please feel free to email myself and Richard, or Yolandi in Richard's absence. I think it's worth us just mentioning that we did have a visit. I'm sure we discussed it in the public part of the meeting last time, that we did have a visit to the maternity services at Calderdale. We will, on the back of that, write to Calderdale, to thank them, but also to raise concerns that we've got around the robustness or fragility, if you like, of the birthing centre at Calderdale. Never mind at Huddersfield. We still haven't resolved the problem around at that. So.
Unknown participant is now exiting.
I think we'll send that letter. And it sounds like we've got another real issue that we need to pick up about children and the community dentistry.
Yeah.
Is there anything else at this stage? I think we've lost Vivian.
Only I was just going to say, of all the various sessions I think we've had presented over the time, I was least impressed with this one. I felt it was not coordinated, it was quite ad hoc, and I thought it was a lot of detailed information that we didn't have. And like we'd said earlier when we talked this morning, quite a lot of it was pertaining to the region rather than Kirklees. I feel this needs, an area we want to look at.
Yeah, I think there's some huge advantages, aren't there, to getting a closer relationship with our commissioners. Okay. Okay. Is there anything else in the formal meeting that we want to pick up? Okay, lovely. Can we close the meeting then? And our next meeting is in April, 5th of April. Okay, thank you.